Anything else you look for in someone who has heart failure? Yeah, JVD, that's a really good one. He actually did have JVD. I think that JVD can be hard to see, jugular venous distension, but this guy was pretty fluid overloaded, so he did have JVD, so I could see basically a shot of blood going up in his neck. Yeah, great question. Okay. Great job, everyone. Okay, so the patient's physical exam. So this guy was resting comfortably in the stretcher. For his cardiovascular exam, he had regular rate and rhythm. He didn't have any murmurs, no gallops, no rubs, no extra heart sounds. So a pretty normal cardiac exam on my auscultation. When I listened to his lungs, in the upper parts of his lungs, his upper lung fields and his anterior lung fields, he had great like air movement, no wheezing, nothing like that, but he did have some crackles in the bases of his lungs, which can be indicative of having a little bit of extra fluid on the body. He was on 2 liters of oxygen, but saturating well on those 2 liters. He's not on baseline oxygen. His abdomen was soft. It wasn't tender. It was not distended. He did have pitting edema to his knees bilaterally, but his legs were the same size. On my just gross visualization, that leg didn't look way bigger than the other, and one wasn't warmer than the other. And then I did a full neuro exam on him. I didn't put in the reflexes, but that was a good question to ask. He knew where he was able to answer all my questions appropriately. All of his cranial nerves were intact. And his strength was intact. I would say his strength was 5 out of 5 in both his upper and lower extremities. But what I did notice is that the patient just seemed to be a little bit more tired. He was like working a little bit harder than I would expect him to. He seemed like he was pretty fit and moved around a lot. So yeah, he just seemed to be, strength was intact, but was working harder than I would have expected him to. Okay. Next, we'll just go straight into his labs. Oh goodness. I don't know why I did that. Okay, so his labs, I went ahead and highlighted the only abnormal lab he had. So it was his sodium. So if you look at the fishbone diagram over on the right-hand side of the screen, we see that a normal sodium should be between 135 and 145. And his sodium was actually 122, which was a little bit shocking to me. That's a pretty low sodium. Everything else, his hemoglobin was 14.5. I don't know why it was twisted around like that. And his hematocrit was 35.6. So within normal limits. And everything else looked pretty much within normal limits. Does anyone have any questions or thoughts on his labs? Okay, great. And then from there, we also had a chest, we had him go for a chest x-ray just because he was using oxygen, which he didn't do at his baseline. And basically the chest x-ray said that there was concern for fluid overload status and he had bilateral pleural effusions. So I went ahead, this was not his chest x-ray, but I did get a check, like this was a pretty similar to what his chest x-ray looked like. Let's see if this works. Okay, so if you can, everyone see like this laser light thing that I have up? Hopefully. So if you look, oh cool, okay, I just learned about this. Okay, so if you look over here, where I'm sort of circling around his bilateral diaphragms, those should be completely clear. There shouldn't be any, there's like blunting there. There's, it's not sharp. Normally in a normal x-ray, you can see very clear, sharp diaphragm limits, and you're not really seeing that here. And so that is concerning that this patient has a little bit of extra fluid in the bases of his lungs, which makes sense with what I was hearing on my exam. And then also up here where they talk about a full fuzzy hilum, basically it's just another side of a patient being a little bit fluid overloaded. And so they have a little bit, they have congestion within their lung space, and that's causing the, them to have, that's a side effect of them having fluid overload. So that was his chest x-ray. So I knew that this patient was quite fluid overloaded, and had a low sodium. So that's sort of what I was going off at that point. Okay. Thoughts on differential diagnoses? Okay. Adrenal crisis. Good. It's good to keep a very broad differential diagnosis. Especially with the sodium like that. Sure. Do you have any specific thoughts, Stephanie, on things with the kidney? Or are you just thinking that maybe his kidneys aren't working the way that they should be working? Good. Yep. Maybe having some problems with his GFR. Yep. He could have a kidney disorder. Great job. Yes, he could have taken too much of his Lasix. People do that sometimes. And that can really cause people to lose a lot of sodium, which we'll talk about more. Good job. Yeah, so we're going to talk about this a little bit more later, Stephanie. So people can have really low sodium from drinking water in a short period of time, like drinking a lot of water. This is actually something that traditionally has been seen in like fraternity hazing events back in the day. This like in the 2000s, this was seen a lot. It's called beer-potomania, and it's basically when people drink a ton of water or something like liquidy and a ton of it in a short period of time, they can drop their sodium pretty quickly. However, it's really, really hard to do that. People have to be drinking like gallons and gallons and gallons of water. But that is a great thought, and that is definitely a cause for hyponatremia. Yes, exactly. Yeah, it happens. It's really sad. Okay. Yes, yep, that's good. People can lose sodium through throwing up and diarrhea. Yeah, awesome job. Okay, so and hypothyroidism. Yeah, that's really great. You all had a much broader differential diagnosis than I did, but these are all things that should definitely be considered in someone who has low sodium. So for me, based off of his initial labs and sort of just the way he looked, for me, I was thinking the first thing I was worried about is that he was having a heart failure exacerbation or worsening of his heart failure because he had all this extra like edema on his legs, which he normally doesn't have. He needed oxygen to breathe, which he also normally didn't need. And so that was sort of one of those things I was originally thinking about. Obviously, hyponatremia due to an unknown cause was obviously on my differential because of that first study or the first lab that we got with him having a sodium of 122. Another thing was medication noncompliance or over compliance, I guess. So was he taking too much of his Lasix, too much of his diuretic, or was he just not taking anything at all? And sort of that could either one of those could cause him to have low sodium. And then lastly, just with the way his chest x-ray looked and him being like a little bit sick, a pneumonia or some type of an infection is always going to be on the differential for me. Okay, so my assessment of him, this is almost directly taken from my notes. So this is a 60-year-old gentleman who has passed with a question of heart failure and hypertension, who's coming into the emergency department with this generalized weakness, shortness of breath, bilateral leg swelling. He has been drinking more water than usual and noticed that he became significantly more swollen than his baseline. And really his only notable lab at that point was that he had a sodium to 122, which qualifies as hyponatremia. And so for me, the first thing that I decided to do on this patient was to order urine studies on him. So to get a urinalysis and to get a variety of urine studies that we'll go through later. I also went to order more labs. So touching on things that people so astutely pointed out, I wanted to check his thyroid levels. Like, did he have hyper or hypothyroidism? Did he have cortisol problems? Was he in an adrenal crisis? And then also a uric acid. Um, that's a great question, Rachel. How did I know to test for sodium in the first place? So with people who have heart failure, they can have electrolyte abnormalities. And so what we do is there's a lab called a comprehensive metabolic panel that we pull, that we tend to draw on people, that shows us their electrolytes, how their kidneys are doing. And also it shows us how their like liver is doing. And so it's just like a lab that people very commonly get when they come into the emergency department. We're always going to, almost everyone who comes in, we're going to look at their blood count and we're going to look at their electrolyte status. And so it's almost like a reflex thing, but that's a great question. Anyone who has heart failure, I'm normally going to be really concerned about their electrolytes, and that's something I would want to check. And so that's sort of how that came to be. Is yeah, so I checked that as well as some other electrolytes. Yeah, of course. And then from there, I knew that we needed to slowly correct the patient's sodium, and we'll go over why that's so important. And because the patient's sodium was so low, down to 122, I wanted to admit him to the hospital for really close observation. And I'll give you all a minute to write that down. Sure. So in the subjective section, so if you're doing a SOAP note in the subjective section, what I like to write is sort of at the beginning what the patient said. So he said that he had been feeling over the past 3 days a little bit weaker, shorter of breath, and having this bilateral leg swelling in the setting of drinking more water, because he was down south for the first time in a long time, and this led him to feel a little bit more swollen than usual. So when we think about the subjective section, that's normally what the patient is reporting to us as medical providers. Did that answer your questions, Alexis? Okay. Do people need more time to keep writing? Let me know. There's no rush. Okay. We will move forward then, but if you need me to go back, please let me know. Okay. So we have been talking, I've been talking about hyponatremia for the past about 20 minutes. What's hyponatremia? So hyponatremia happens when the serum sodium, or the sodium in the blood, is less than 135 milliequivalents per liter, which is the way that we measure electrolytes in the United States. So hypo, if we like break this down by Latin, like like Latin roots, hypo means like low or under. Nat, like NATR, means like salt, basically salt or sodium. And then emia is anything in the blood. So if you, in medicine, if you hear like bacteremia, that means that there's bacteria in the blood, or fungemia, there's fungi in the blood. So anything with an emia on the end means that's in the blood. So we have low blood sodium. In this case, the sodium is less than 135 milliequivalents per liter. So anything under 135 on a CMP or a BMP that you draw a metabolic panel, you would be concerned about hyponatremia. So why does it happen? There are a variety of reasons that it can happen. There tend to be two major reasons. Either the sodium in the blood is diluted because there is excess water, that we're holding on to excess water, or there is increased sodium loss. So it tends to be one or the other, but sometimes it can be both at the same time. Things that can cause hyponatremia include vomiting and diarrhea, like someone mentioned, diuretics, so this pill that the patient was taking, Lasix, can cause it, inadequate salt intake. So sometimes you'll see like really elderly people who have only, they call it the toast and tea diet, where they don't eat anything with any salt in it. They just literally eat toast and tea and that's it. This tends to happen later in life when people are declining, but we see hyponatremia in them. And then some other reasons that aren't listed on here is going to be the increase in intake of water, like we mentioned earlier, but it has to be like a lot. A lot. And then also we see, we can see this in cancer and the type of lung cancer quite often. Okay. So on a more cellular level, what exactly is going on? So when we think about hyponatremia, what happens is that there is low sodium in the blood, like we started off talking about. And because of that, when there's low sodium in the blood, what happens is that there is lower pressure in the extracellular fluid. And so everything in, if you take like biochem or if you've taken like an anatomy and physiology class, everything with electrolytes and water works on an osmotic system. And so it's basically taking the path of least resistance, and water sort of follows the path of least resistance. And so if there's low oncotic pressure in the extracellular fluids, that means that the water is going to shift out of the blood cells and shift into the interstitial fluids, or basically outside of the cells. And what happens when that happens, we see that as the water shifts out of the blood cells, we end up having more water that goes into the interstitial fluid, which causes we see higher osmotic pressure within the cell. And then from there, bad things happen, right? When we have too much water in a cell, the cell dies because it gets too big, it ruptures basically, and it dies. So this is sort of the general reason why hyponatremia is bad. It eventually leads to cell death through cell edema and rupture. Any questions on that? Also, feel free to speak aloud if you want. It's so quiet today. Okay. And so with hyponatremia, we classify it at different levels. So there's mild hyponatremia, moderate hyponatremia, and severe hyponatremia. Mild hyponatremia is 130 to 134, so right underneath that level of 135 that we talked about. And then mild hyponatremia, people tend to have headaches, nausea, feel a little bit confused, and have muscle cramps. Moderate hyponatremia is going to be 125 to 129. And people with moderate hyponatremia tend to have headaches, tend to have problems walking, they have decreased reflexes, and they just feel like tired, sort of run down. Severe hyponatremia, anything under 120 is where we become really concerned. Between 120 and 125, it's sort of a gray zone. It sort of depends on where the person lives at baseline with their sodium levels. But anything under 120, that's going to be really scary for a medical provider, because with sodiums that low, we tend to see people who have seizures. They become delirious. They have brainstem herniation, because sort of going back to that last slide that I was talking about, when all of the water shifts out of the blood into the interstitial fluid space, things start to rupture and like get bigger, right? And so if our brain is in a very small skull, it's fairly big, but not big enough for it to expand like that. So if our brain starts to expand rapidly, what happens is that our brainstem literally herniates, and that's that causes death, or at least brain death. And because of that, people have respiratory arrest, coma, and death. So pretty serious stuff. Any questions on that? Okay. So our dear patient, Mr. F, was suffering from hyponatremia because of his heart failure. So when someone has heart failure, can someone tell me like what happens when someone has heart failure, sort of the basics, like what's the problem when there's heart failure?
Isn't heart failure like a condition, like a chronic condition where your heart, some parts of it, like whether you got a heart attack or a mild one, it doesn't pump as much blood as it should, and different parts of it, or they don't receive as much oxygen in the blood, depending on what level of congestive heart failure they're at.
Yeah, great job, Natalie. That's exactly right. So when yeah, the heart could be working too hard, their rate of pumping blood is low. Yep, everyone is on the right track. Exactly. So our heart's a muscle, right? Just like anything else. And for the most part, younger people's hearts are like very vigorous, and they can pump really hard, and it pumps blood to everywhere we need it to go, right? It pumps it to our brain, to our kidneys, to our lungs, like everywhere, right? And so that's why we are able to go on runs and be okay for the most part, or do very vigorous activity, and our organs won't shut down on us. But yes, exactly. When someone has heart failure, depending on how bad their heart failure is, his heart failure was, it wasn't great, that's for sure. That means that every time the heart pumps the blood in systole, so pump, 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 it's not pumping out blood with the same force or the same amount of blood that it should be. And because of that, the organs are hypoperfused or not getting enough blood. Are you asking if the person had like hyperplastic syndrome, Rachel? Yeah. So he didn't, but that can be a reason for heart failure, right? Because in that case, the blood with left ventricular hypertrophy, the a person's not able to get enough blood into their ventricle to push out how much they need to. But this man, Mr. F, had just globally a weak heart, honestly. And so because of that, he wasn't able to push out what he needed to push out. And so because of that, he wasn't getting enough blood to his kidneys, to sometimes to his brain, to all of his important organs. And so when that happens, this can cause people who have heart failure can get hyponatremia in two different ways. Okay, so the first way, let me get my laser thing again. Okay, so we'll go over the first way. So the first way is going to be on the left side. So even though Mr. F was pumping out blood and his body was doing its best to get blood to its kidneys, it just wasn't doing a good job. It wasn't getting enough blood to the kidneys. And so when that happens, the kidneys become confused and they're like, oh, we're not getting the same amount of blood that we thought we were getting. So maybe we shouldn't be making as much urine as we usually do. And so when someone has heart failure, like really bad heart failure, what happens is that the kidneys aren't getting enough blood, and so they vasoconstrict, or the arteries become a little bit smaller, all the vessels become smaller in an effort to shunt the blood elsewhere, and try to put it to better use elsewhere. And so when that happens, we see that people tend to activate basically a system in the body, which some of you may have learned about in biology, called the renin-angiotensin angiotensin aldosterone system, which is a hormone system that's used to regulate fluid and electrolyte balance. And so with the patient's kidneys not thinking that he wasn't getting enough blood, the kidneys are like, okay, well, we need to figure out how to increase our filtration rate. How do we get more blood to us? Because they do that vasoconstriction, but then at a certain point, they're like, well, we need blood too. We need to get rid of some urine. And so what happens is that a hormone called ADH increases. And ADH is anti-diuretic hormone. And basically, this leads to the kidneys thinking that it should just hold on to everything. So normally when we urinate, we try to get rid of salt. We try to get rid of things that we don't really need. We get rid of some water, but the kidneys become confused. And so they hold on to everything. And so instead of getting rid of sodium and salt going down the kidney, going down the tubules, which we'll go over next, they sort of just hold on to everything out of fear. Okay. And so basically this guy is holding on to salt and to water, more water than he should be. But he's holding on to more water than he is salt. And so because of that, he becomes a little bit fluid overloaded and also is keeping and is also diluting out all of the salt in his bloodstream because he is holding on to way more water than he is salt, but it sort of goes together. Does anyone need any clarification on that? I know that this is a very complex topic and there's a lot going on. And any questions, a valid question, honestly. Yeah, SNS is going to be the sympathetic nervous system. So when I talked about the RAS, the renin angiotensin system, aldosterone system, that's basically anything that sort of like gets the body going. And in this case, it's going to be RAS. Okay. We can go over the other portion now. So that's one way in which we start to see the patient having hyponatremia and having those symptoms of heart failure. So like the edema in the legs and the fluid overload status in the lungs. Another way that we start to see this is that basically when we activate that RAS system, so we see angiotensin 2, what that does is it activates our thirst center. Does anyone happen to remember from like a neuroscience class or biology class where our thirst center is? Oh my gosh, everyone is so on it. Amazing. I love it. Great job, everyone. Exactly. It's in the hypothalamus. And so what happens is that we see that angiotensin 2 works on the thirst center, aka the hypothalamus. And when we feel thirsty, right, we're going to drink more water. And the more water we drink, the more that we hold on, that he starts to dilute out his sodium concentration a little bit, and the more edema he's going to have, right? Because unlike him, his heart's not beating the same way it should be beating, and his kidneys aren't wanting, because his kidneys are confused, they're not peeing out the same amount of urine that they should be peeing out. And so it's sort of a vicious cycle. So this guy is sort of like in a catch-22 where he feels thirsty, more thirsty than he should, because his kidneys are basically confused. And so he's not peeing like he should be, but then he's also making the situation worse because he's drinking more water. And so it's sort of like a catch-22. And it's honestly really unfortunate. Any questions on that? We're going to break down the kidneys and like the hormones a little bit better in the next slide. Okay, great. So this was something I used personally to study when I was in medical school. looking at the renin, angiotensin, aldosterone axis or system and the nephron. So that's going to be our building block of the kidney. And so when we have a low renal perfusion pressure, when the kidneys think that they're not getting enough blood, which they're truly not in someone who has heart failure, we see an increase in the secretion of renin. When renin is secreted, that leads to an increase in the secretion of two hormones, angiotensin 2 and aldosterone. Does someone happen to remember what either angiotensin or aldosterone do from any of their classes? And feel free to say it aloud. Yep, good. Yep. Yeah, that's all right. So yes, exactly. So yes, with aldosterone, we tend to retain more sodium and then get rid of, yep, exactly. We get rid of our potassium with aldosterone. And then yes, which then in turn increases blood pressure. So great job, everyone. That is exactly right. And so if we look at this side of the diagram, what we see is that angiotensin 2 is going to really work on the proximal tubule of the kidney, and then aldosterone works a little bit later. And so if we go back to our previous slide, come on. Okay, great. So if we go back to our previous slide, we see that if you look at this portion of the slide, we see that angiotensin 2 works on that proximal tubular portion of the kidney where we see increased sodium and water reabsorption, whereas aldosterone is going to work a little bit more distally, and we're going to see that aldosterone won't let water or salt escape basically from the kidney to go into the ureters to pee. And so that's what's happening in this system. Really awesome job on the basic science knowledge, everyone. This stuff is really tough. Okay, and then ADH, antidiuretic hormone, which is also called vasopressin. And so just like everyone so adeptly mentioned, we know that with ADH, what happens is that they're basically what occurs is that our bodies are pretty smart. And if our bodies know that we have, if our body thinks that we have a low blood volume, which happens in heart failure, what they do is they send signals to the hypothalamus, which then creates the sensation of thirst. And so these receptors then stimulate ADH, which then makes us thirsty, makes us drink. That's pretty much it. And when we drink water, what happens is that we have an increase in blood pressure. And yeah, that's pretty much it. Any questions on that or any other thoughts on how ADH can play into all of this? And then this is just going to be a good example of the inside of a kidney, right? And so this is what we expect to see over the course of the filtration, where we eventually make urine. However, as we saw on the previous slide, when the RAS system is activated, everything is sort of messed up. And so we see that we're not getting rid of sodium. We're not getting rid of the sodium in the water like we would expect to, but rather the body is sort of in a survival mode and it's a little bit confused. So it's trying to hold on to everything. But at the end of the day, it's holding on to more water or H2O than it is sodium. And that is what ultimately causes hyponatremia in people with heart failure and causes them to make less urine, and then causes them to be fluid overloaded. and these are like the basics. It gets a lot deeper than that, but sort of on a, like a very surface level, that's the way that at least in emergency medicine and in the ICU, we tend to think about it. Okay, so how do you officially diagnose hyponatremia? So, like I mentioned before, what we just went over was specifically hyponatremia in the setting of heart failure. And so what that is called hypervolemic. So this person has more volume on their body than they should, hyponatremia. But there are so many different types, as I'm sure you can see by this diagram. There's so many different types of hyponatremia. And so the things that we're going to want to look at with hyponatremia, I would pay attention here and keep this slide on hand for your quiz, is going to be the first thing you want to look at is the serum osmolarity, because if someone has true hyponatremia, means that the person has a low serum osmolarity, versus a fake hyponatremia. For example, someone has really high glucose or sugar in their bloodstream, or if they have a lot of fats like hyperlipidemia, but like really, really high, we can see like a fake displacement of the sodium in the blood, but that's not actually true. And so what the first thing you're going to want to look at is the serum osmolarity, which can either be ordered or you can calculate it yourself. And then from there, the reason I mentioned to get urine studies is because you're going to want to figure out what type of hyponatremia it is. And while normally it's easy to distinguish between someone who's hypervolemic and then hypovolemic. So if they look like really dry and just look like, they haven't been adequately hydrated in a while, those are pretty easy to tell. But it's going to be the euvolemia, are people who sort of look normal like you or I, who are a little bit more confusing, and that's why it's so important to get these studies. And then obviously people who just are excreting normal amounts of water. And so the next thing we're going to look at is the urine osmolarity. If their urine osmolarity is low, not really that interesting anymore, but what we want to see is a high urine osmolarity, because what that means is that there is an impairment in the water excretion. So going back to the RAS system, going back to the person's ADH, leading them to drink more water. Basically, people tend to hold on to a little bit more water, and they're not getting it out correctly. And so from there, if we have a high urine osmolarity, what we then do is look at the patient's volume status. There are a variety of ways to do that. Sometimes, in someone who has heart failure or cirrhosis, you would see the edema everywhere. But if it's someone who tends to be hypovolemic or not have enough, you can look at their tongue. So if they have a dry tongue, you can pinch their skin. Some people are so dry, like when you pinch their skin, it stays sort of pinched up, which is a little bit scary. And then also just looking for any other signs of being dry. And then apparently the most accurate way to tell this is actually to look under someone's underarms and see if they have any sweat there. If not, then someone's actually quite fluid down. I just learned that the other day. And then, or someone could have be volemic and sort of just be at a normal spot. And so for our patient, we would want to see that he has a high urine osmolarity, and then if he ended up having hypervolemic hyponatremia, we would want to look at his urine sodium. If his urine sodium is less than 20, that sort of points to a heart failure. And if it's above 20, then that points to another etiology of his hyponatremia. So sort of using this, and this is something that's often used sort of to say okay, what type of hyponatremia is this? This is a really good graph to use. Okay, so Mr. H's lab. So his serum osmolarity was 272. His urine osms were 125, and his urine sodium was 15. So if we go back, so his serum osmolarity was 272. So that's true hyponatremia. His urine osms were 115. And so that's pointing towards him having the impaired water excretion. And then his urine sodium was 15. And so because he seemed fluid overloaded on exam, that was pointing most likely to a congestive heart failure cause of his hyponatremia. Okay, so we have all of his labs. We know that his original sodium was 122, just as a reminder, and he really fits the picture for hypervolemic hyponatremia. So for treatment is going to vary widely for hyponatremia, depending on if someone is in the emergency department versus if they're in the ICU versus what type of hyponatremia they have. For this patient, his hyponatremia was due to him being fluid overloaded, right? He had too much water in his body and didn't have enough sodium to accompany that water. And so because of that, what our treatment would be for him, which is actually quite simple, is to water restrict him. And so he was water restricted a little bit severely. We kept him under 750 mLs of water for a few days. Additionally, if someone isn't, once they become water restricted, if they're not peeing, you're making urine or urinating out what they need to, a good thing to do in heart failure specifically would be to give them diuretics and basically have them get out all of that that extra water that they're holding on to. They'll also get rid of a little bit of sodium as well, but the amount of water in comparison to the sodium they get rid of is going to be like hugely different, and it's going to be really important to get them to the next, basically get them to be back at euvolemia or back at a normal fluid status. And then lastly, making sure to slowly correct the person's sodium. And so for us, we recheck labs every 4 hours, because if you correct sodium over 10 to 12 basically points a day, there are extremely negative complications. So anything over 10 to 12 milliequivalents per day. So if he started out at 122, within 24 hours, I wouldn't want him to go higher than, 130 to 134. And we tend to correct even more slowly than that in real life. So does anyone have any idea what happens if someone's sodium's corrected too quickly? Oh my goodness. Yeah, that's it. Yeah. The pons will shrink away from the myelin. Exactly. Yeah. So if we go from low to high too quickly, so the pons will die. And so what this is called is central pontine myelinolysis. And so what we see is that the myelin, which insulates our neurons, is destroyed, specifically in the pons. And this happens when sodium is corrected over the 10 to 12 milliequivalents per liter per day. And what happens in this syndrome, it can be quite severe, actually. I've seen it once. People can have locked-in syndrome where they only are able to move their eyes. Additionally, we can see that people can progress to death. And so what happens in central pontine myelinolysis is that there's a destruction of that sheath around the pons, because when we have a decrease in sodium in the bloodstream, there's increased water that crosses the blood-brain barrier, which leads to the increased brain volume like we talked about. That's why it can be really bad to have really low sodium levels, because the brain volume sort of expands out. And if it expands out too much, that can lead to death. However, when you have all that water in the brain and then you start to quickly correct someone's sodium in their bloodstream, what happens is that all of that water basically rushes out of the brain, out of the interstitial fluid, and goes right back. It wants to go where there's higher concentration, right? And so that's going to be back into the blood. And when that happens, the cells are damaged. So these cells that were once like really big and plump basically shrink down quickly, become damaged, and they die. The cells die. And so this can lead to serious consequences, including respiratory failure, coma, and death. So pretty serious stuff, and that's why physicians tend to take it very seriously. Okay, so the main takeaways. Could that be caused by drinking DI? What does DI stand for? Should I know this?
DI is like a deionized water, pure H2O, no ionization at all.
I would have to look that up and get back to you. I actually don't know. Yeah, I'll look that up and I'll get back to you because I really have no idea.
Mineralized water, just pure H2O. So I mean, water has a lot of minerals that balances. Yeah.
That's a really good question. Yeah, I'm not really sure. I would have to look that up. Thank you for your question. So some takeaways from this. So we went pretty deep into the pathology, but I think that the pathology is good to know, but really what hyponatremia is and what causes it most commonly is going to be a little bit more important. And so hyponatremia is either caused by increased water absorption or increased sodium loss. Very rarely is it caused by not consuming enough sodium. Once again, those are going to be the old people who drink tea and eat toast, and that's it. We know that multiple things can cause hyponatremia. So that's heart failure, vomiting, diarrhea, extreme diuretic use are going to be some of the main ones. And when diagnosing hyponatremia, it's really important to understand the type of it as well as the cause. And so for Mr. H, he had volume overload hyponatremia, also known as hypervolemic hyponatremia. And so the treatment for him personally was to decrease the amount of water that he was consuming and try to increase the water that he was getting out of his body. This is not always the case, but specifically in heart failure hyponatremia, that's the way that you want to treat that. And then if a person's sodium is corrected too quickly, they can have CPM or the central pontine myelinolysis, in which they can have terrible consequences, including and up to death. These are my sources. Thank you everyone for joining in. What questions do you have? Let's see, what do we do for the person during the slow correction process? Yeah, so basically as long as someone isn't seizing or on the verge of death, they sort of just ride out their symptoms. You know, if someone's having cramps or a little bit confused or having some vomiting, those are all things that we can treat or at least make them feel better for. But the risk of overcorrecting their sodium is a lot more dangerous and consequential than them feeling like a little bit weak for a few days. But if someone is seizing or is having severe neurological symptoms from their hyponatremia, then we're going to correct that really quickly or correct it back to a good baseline so that they're not going to die, so that they'll stop seizing, so that their brainstem won't herniate. Yeah, but any of the other symptoms, like the more mild or moderate symptoms, they sort of just wait it out. Oh yeah, that's a good question. So let me go back to that. So VEC, this was a paper that came out of Italy, I think, and so some of it wasn't in English. VEC is going to be extracellular volume. So the volume that's outside of the cells. Yeah, which we know is already a little bit low in people with hyponatremia, right? Because they have the shift of water into their cells because of osmosis.
Question.
Sure.
So, like for example, like my mom has Graves' disease, and so like I noticed a lot of times, like whenever she does a lot of walking, she'll get edema like in her lower legs. So is that caused by like hyponatremia in the body, or is that just like a symptom of just having Graves' disease and a common occurrence?
Yeah, that's a really great question. So no, that's most likely not caused by hyponatremia. Some people just have something that's called third spacing, or fluid that goes into their interstitial space, but that's not always due to low sodium. That's just like one of the reasons that can happen. But honestly, that happens to a lot of people. Like if you look at people who are on planes, like 16-hour plane rides, 16-hour plane rides or something, they have that swelling. So sometimes we can have pooling at the bases of our like our legs, basically, because of gravity. Did that answer your question, Matthew? Okay, cool. So let's see. I think I'm a little confused. The end thought was that this man was having hyponatremia due to heart failure. So, that's a really good question, Cecilia. So his blood pressure was normal for him. So he had pretty severe heart failure. And so his blood pressure, if I remember correctly, upon presentation was about like 85/60, which in someone who is like you or me, or well, I don't know, some people tend to have lower blood pressures, but in someone who has heart failure, that's where they tend to live. And so he said that that was his baseline blood pressure. And so that is sort of what I was going off of. So it was his normal blood pressure, but if any other older elderly person without heart failure came in with that blood pressure, I would be really concerned. Please don't call me Dr. Banks. Yeah, of course, everyone. Thank you for coming. I really appreciate it. I'm excited to do more of these. And if you have, please give any feedback if anything could be simpler, or if the diagrams weren't clear enough, please let me know, because I'm here to help you all learn. Okay. Anything else, Becca? Oh. Okay. Well, thank you so much, everyone. I hope you all have a great night.